Hi, my name is Jack Aiello, and I'm a 28-year survivor of multiple myeloma. I remember in 1995 when I was diagnosed, and the doctor told me I had 2 to 3 years to live, and there were only two treatment options available. I remember going home to my wife, told her the little bit I understood about this disease, and suffice it to say, we shared a good cry. And since then, we've had 13 or 14 new drugs approved by the FDA and more combinations of these drugs. And even more are in clinical trials today. I really believe that for today's newly diagnosed patient, you can be more optimistic about your diagnosis than any time in history. While we don't have a cure, as I've said, we have treatments available to manage this disease. Here to help us understand more are Doctors Ajai Chari and Dr. Sandy Wong. Dr. Ajai Chari is Director of Clinical Research at the Multiple Myeloma Program in Mount Sinai in New York. And Dr. Sandy Wong is a blood disease specialist at the University of California in San Francisco with a special interest in myeloma. Let's kick off the conversation with what was the big buzz this year at ASH, bispecific antibodies. We've heard of monoclonal antibodies like daratumumab. Most recently, the FDA approved a bispecific antibody called talquetamab or Tecvayli. So what exactly is a bispecific?
The first naked antibodies were daratumumab and elotuzumab, and those basically bind the true Y-shaped structure. The ends of the Y shape bind to one target, and typically that's the myeloma cell or whatever cancer cell. What's different about bispecific antibodies, depending on what people are into, but it's either a handcuff or double-sided tape. So basically what it does is it takes one side of the Y, binds to a T cell, to a target known as CD3, and the other side can bind to a myeloma cell, and you can change that up based on the protein. So the one that's commercially available now, that's called talquetamab, binds CD3 on the T cells to BCMA or B cell maturation antigen.
The talquetamab that was just approved and other bispecifics, just to let the readers know, are so far for relapsed refractory patients. Those are patients who have gone through several lines of previous treatments before getting to these bispecifics. Is that correct?
Yeah, that's exactly right. And just to put this whole space into context, about say 5-6 years ago, the way drugs get approved is that they're first tested in heavily treated patients, as you mentioned, relapsed refractory myeloma. And the benchmark to get a new drug approved was about 20 to 30% response rate, lasting about 3 to 4 months. And those numbers sound modest, but we have to keep in mind, those are in patients who had exhausted all available therapies. So, when I started in myeloma 17 years ago, thalidomide was just coming on the scene. And so at that point, relapsed refractory was, okay, you had thalidomide and maybe a transplant. Now, we're talking about the big 5 drugs, lenalidomide or Revlimid, pomalidomide or Pomalyst, bortezomib or Velcade, carfilzomib or Kyprolis, and CD38 antibodies such as daratumumab or Sarclisa. And that is a very different patient than somebody who just had thalidomide. So as we keep approving drugs, this, what we call unmet need, which is patients who've exhausted their currently available therapies, keeps changing. And in spite of that, what's remarkable about the entire what we call T-cell redirection, whether it's bispecific or CAR Ts, we're saying 70 to 100 is the new 20 to 30, because that's how many patients are responding to these drugs. Even though these are much, much sicker patients and have had more treatments, more drugs, we're getting better responses. And that's what's really exciting. I literally have patients whom we had discussed hospice a few years ago, and now they're in their deepest, longest remission they've had in years. And it's a mind-changing, game-changing era that we're in with this immunotherapy treatment.
For one who's been watching new treatments being developed and now seeing 60 or 70% response rate just for an individual drug, it's pretty incredible. Dr. Chari, you presented on a different bispecific called talquetamab, also from Janssen, the same manufacturer of talquetamab. Can you share the results of this trial and what might make talquetamab different from other bispecifics?
Even though these are 60 to 100% response rate, we're still seeing relapses. So you still need new agents. And so that was the goal of this study, to really look at these three subgroups. And I would start with who these patients were. These were patients with heavily treated disease. About 60% were high risk in some way, which is a very high number. And that could be defined either by high risk, what we call genetics, so cytogenetics in fish, high risk because they had myeloma coming out of the marrow, what we call extramedullary disease, or high risk because they had so-called ISS stage 3 disease at the time of study entry. So in this population with a typical 5 to 6 lines of therapy over 6 to 7 years, where almost 95% of patients were refractory to daratumumab, 75% were what we call triple class refractory, so proteasome inhibitor, IMiD, and a CD38, and 95% of patients were progressing on their last therapy. So in this heavily treated group, as a single agent drug, we saw 73 to 74% response rate in both of those schedules that we mentioned. That response rate was maintained in high-risk patients, in ISS3 patients, in patients with, regardless of lines of therapy, regardless of the number of drugs they were refractory. The one group that had slightly lower response rate was those with extramedullary disease, and even those had a 50% response rate, which I think is outstanding. But I think the safety is also equally important and distinguishes this from some of the other drugs.
Thank you, Dr. Chari. Dr. Wong, you presented on a bispecific called alnuctamab from Bristol Myers Squibb. Can you share the results of this trial and what might make alnuctamab different from other bispecifics?
We presented both the updated follow-up on the intravenous alnuctamab cohort as well as the subcutaneous alnuctamab cohort. And the intravenous cohort was actually presented initially in ASH of 2019. So there's been quite some time that's elapsed. And basically the take-home message with the IV alnuctamab was that even though the response rates initially looked exciting, there were really, when we got to target doses of 10 milligrams, there were just a lot of CRS, high-grade CRS, that stands for cytokine release syndrome. People got really sick from CRS, and actually one person died from it. So it was not really suboptimal in terms of the side effects. We don't want people to really obviously get sick from these treatments. However, those patients that were dosed on the intravenous alnuctamab, those people that responded for a really long time. So we're really excited about that. However, we had to pivot to the subcutaneous alnuctamab because of those safety concerns. And what we see with the subcutaneous alnuctamab was at the overall, in terms of the overall response rate, it was actually awesome. It was really great. It was at 65%, which is very much in line with other T-cell engagers. But what is really exciting is that the MRD negativity was 80%, despite these patients having been followed for that long. So that is actually really exciting. So basically, to answer your question, is we don't have a signal for high-grade infections, though, or opportunistic infections, though. Again, follow-up is pretty short with this drug.
Speaking of infections, what are the common side effects we're seeing with bispecifics altogether? And I understand some research is unearthing data about how myeloma patients on certain drugs do with COVID and the vaccine.
Yeah, I'll start with what's the most severe toxicity, and then we'll go to what's common, because I think they're different and they're both equally important to address. Because from a patient perspective, if it's severe but rare, you may not be as concerned, but if it's common and frequent, that's a different, right? So starting with the most severe side effect is really the low blood counts. And so we see that in about a third of patients with this drug. Typically, it happens in the first few cycles. And my personal hypothesis, I think what's happening is when the army's going to the marrow, where a lot of myeloma lives, yes, you kill the myeloma, but you may temporarily also affect the rest of the marrow. And then once the myeloma clears, you see that improve. So about a third of patients.
Patients may hear that called cytopenia. Is that correct?
That's exactly right. It could be the white cells, the red cells, or the platelets. And so those are important, but this is already a little bit less than some of the other drugs, which can have as high as 60%. And so this is about half of that. The second huge thing which you alluded to, and it's very important, is the infection. And I can tell you, being in New York City in the pandemic, this was really difficult situation. I mean, we had patients on experimental therapies, and we were facing these life-threatening COVID decisions every day. And so we didn't know what to do with this setting. And so I think the infection profile of this talquetamab is very unique. And then I'll give you 3 ways of why I think it differs from some of the other products. First is the rates of severe infections was about 10 to 15%, which is still, we want it to be 0. But to put that into context, some of the other drugs are 45%. And we're not just talking minor infections, which can be seen with any myeloma patient because of the nature of the disease, but this is severe life-threatening infections, right? What we call grade 3, 4. And so that was relatively modest. Second, the COVID signal is very different with this agent. Both the talquetamab as well as a lot of the other bispecifics are all accruing during the era of COVID. And yet in the phase 1 study that was published in New England Journal with about 250 patients, there were 0 COVID-related deaths. And in this study, there were 2 COVID-related deaths, despite 10% of the patients having COVID. And so that's a unique signal. And in fact, in our laboratory at Mount Sinai, when we've tested people getting talquetamab, their response to the COVID vaccine, they do very well. They're able to generate antibodies, which we don't see with some of the other bispecifics because of the nature, I believe, of the target. And the third and final difference between this drug and some of the other bispecifics is the need for infection prevention treatments. What you alluded to, is there anything we can do to reduce infection? And there is IVIG, which is intravenous immunoglobulin, and that's an intravenous infusion given once a month to boost the good IgG levels. And here, only about 10% of patients needed IVIG. And so all of those features of this drug are very unique. Some of the other products are having as high a rate of 40% of patients needing IVIG. And I think this bodes well because these are probably the 2 most important features, which is the cytopenias and blood count and infections, in terms of how these drugs are used in the future, because the ability to combine drugs depends on each agent's side effect profile. And because infections are quite common and because blood count issues are quite common, that can make some of these bispecifics difficult to combine. And I think that, in contrast, bodes well for talquetamab. But there are some issues with talquetamab that are common, but typically low grade. So one you've alluded to, which is cytokine release. I would say as a class, all the bispecifics have cytokine release syndrome on the order of 70% or so, typically low grade. In contrast, some of the CAR Ts have a little bit higher, more severe cytokine release. So what is cytokine release? It's when the army recognizes the cancer, the T cells, they release their chemicals, and those chemicals can cause symptoms such as fever, low blood pressure, low oxygen, confusion, lethargy, seizures, and even in rare cases, death. With bispecifics, it's generally very low grade. Most of the patients are getting a fever.
So let's just summarize the side effect profiles for these bispecifics. I would stay on bispecifics typically until they stop working. I take them every 2 or 3 weeks, depending on how they are dosed. Although I know there are some clinical trials looking at giving bispecifics for a fixed duration. Do these side effects change? Are they worse at the beginning? Whatever side effects I get at the beginning, do they continue as I'm taking the drug?
There's 3 major bispecific targets that are being explored. We've talked about GPRC5D with talquetamab. There's actually a second company also pursuing that was also presented at ASH from Roche, targeting GPRC5D. The BCMA is a very busy space. I think it's like the statins of myeloma, right? Like Crestor, Lipitor. It's like, but it's great for patients because more competition means more choice, better cost profile. I think it's great for the market. But I would say the BCMAs seem to keep having a rate of infection that we don't see a plateau in. That's what's concerning to a lot of us, is how do we find the right dose, schedule, and duration? Because it's one thing to have an infection in somebody whose myeloma is uncontrolled, because that we've seen before, that myeloma patients whose myeloma is uncontrolled will get infections because that's part of the cancer. And what can be sometimes difficult to tease apart in these single arm studies is you can't isolate out what's coming from the patients, like if the patient is a very sick patient, what's coming from the disease of the myeloma itself, and what's coming from the treatment, because you don't have a control arm in which to compare it to. But one of the things is, as your question astutely asked, is there any change? And with the infections, we're not seeing that level off with the BCMA. With talquetamab, we're not seeing it as much. And I would say with the cevostamab is probably somewhere in between. That's targeting another protein called FcRH5. So I would say infections, we haven't found the right magic sauce yet, perhaps IVIG. But one other interesting paper that I think speaks to this topic is the same company, Genentech/Roche, that did the prophylactic or preventative TOSI, also happens to have the only bispecific that is a fixed duration. So they don't treat to progression, they treat for about a year. And what we saw is there's a small number, but about 17 patients that had come off the therapy and were in longer follow-up on that study. And what we know so far is of the patients that had a deep remission, they've been doing pretty well off therapy, which again is amazing for patients to have a treatment-free interval. With talquetamab, because we're not seeing that relentless increase in infection, and to the opposite, the side effects like the skin, nails, and the taste actually seem to get better with time, there may not be as much of a need to do the fixed duration there. Maybe it's once a month dosing or something. And so we're pursuing all of these different strategies. But I would say that we got to look at everything. We got to look at the dose. We have to look at the frequency. We have to look at the duration of treatment and figure out for a given patient based on a given target and based on their response. Because that cevostamab data, which discontinued, for those patients that were not in a complete response, they did have earlier relapse. So I think you can't have a blanket statement. I think you just got to look at each patient as an individual. But it's nice to have these options that are giving such outstanding responses.
Thank you so much. I've learned a lot about bispecifics. I can tell you there's also a lot of work still to do to understand the dosing, to understand if there will be prophylactics that go along with them to minimize those side effects, to see if fixed duration or use till progression will be the right treatment or just to reduce the dosing going forward. I still go back to what you said earlier, that we're seeing response rates so high for just this drug, not even combined with something else. And for patients that have already gone through lots of prior treatment lines, it's certainly an exciting field.
Just to add to that, not only are we seeing these responses, the median time to response is 1 month, and the median time to best response is 2 months. I mentioned those points because it gives us as physicians a lot more comfort in backing off on the dose and schedule, right? Because you're seeing the response early and it's deep. So if somebody has side effects, you're not as worried about backing off, right? And that's what's really nice about these drugs. Even if somebody does have side effects, it's very gratifying to them to have this myeloma that was shooting off and suddenly it's completely flattened out. And then people are willing to, so that's why I think the side effect profile, we got to do more work on. And to that point, in case people are listening, what are the next steps? So all of these phase 1 studies require confirmatory, all the phase 1 and phase 2 single arm studies have confirmatory randomized studies where the drug's being combined with different backbone agents. And also talquetamab in particular, because of the unique side effect profile, is also being combined with all the standard myeloma drugs in single arm studies, as well as with the other bispecific, which is really cool, right? Completely chemo-free teclistamab with talquetamab is being studied. And lastly, we're trying to also improve the T cell function because we think perhaps one of the reasons the drugs may peter out is because of T cell health. And so there's approaches using things like checkpoint inhibitors, which boost your T cell function in combination with these agents.
The bispecifics are here, and it's a dawn of really a new era because finally we have a off the shelf drug, which means that you can just take it, right off the shelf and just give it to a patient. And for an off the shelf drug to have a response rate of 60 to 70%, that is absolutely amazing, right? Previous to this, DARA was our darling drug, right? Because the DARA, and we use it so commonly nowadays in the frontline setting, in the relapse setting. And and you're absolutely right, Jack. When DARA was FDA approved, the single agent by itself response rate in patients who are relapsed refractory was only around 30%, right? Now we're hitting like 60 to 70%. So this is extraordinary. And it's not just one drug, we have multiple drugs against multiple targets that are showing such an impressive response rate. So I think it's really good news, this ASH. I'm really excited to see all that amazing data being presented.
So I think it's a really exciting future. We're just on the beginning. And of course, in less heavily treated patients is also a big area of investigation in addition to combination. So stay tuned for all of those exciting new studies to result out hopefully soon at a theater near you, right?